The labrum is a bowl-like piece of cartilage that sits in the glenoid fossa. A common injury associated with this structure is a superior labral tear from anterior to posterior. It is abbreviated to slap tear. Slap tears are common amongst a few groups. The repetitive motion seen in throwing athletes can grind down the labrum and eventually perforate it. Trauma can also cause slap injuries due to forceful impacts commonly seen in football and hockey. Finally, older populations are at risk due to decreased cartilage thickness and decreased bone mass, or osteopenia.
Individuals who have sustained a slap tear commonly experience a feeling of instability in the joint, dislocations or subluxations, an impaired range of motion and strength, catching, grinding, popping, or locking of the shoulder joint. There are 4 types of slap lesions that increase in severity.
Type 1 is characterized by general wear and fraying of the labrum. Similarly, Type 3 is a detachment of the labrum from the glenoid fossa. 1 and 3 can be surgically debrided and cleaned. However, Types 2 and 4 are slightly different. 2 and 4 include the biceps brachii, meaning both surgeries require the labrum to be reattached to the bone via sutures. Rehabilitation begins about a week post-op. Each phase builds on one prior to it and executed intentionally to return the athlete to play.
First, Phase 1 begins a week post-op and extends 4 to 6 weeks. It is comprised of exercises to increase glenohumeral range of motion, activate the rotator cuff muscles, and improve neuromuscular function. Cardio may be included as well, however, athletes should avoid exercises that cause shoulder movements such as running. Gentle proprioceptive neuromuscular facilitation, or PNF, distal to the shoulder is a common exercise for this phase. During this exercise, the athlete sequentially flexes the fingers, wrist, and elbow, then extends the fingers, wrist, and elbow. A trainer will resist their movement throughout, causing the involved muscles to contract. Likewise, submaximal shoulder isometrics involve the athlete resisting a trainer as they try to execute internal rotation, external rotation, abduction, and adduction.
Second, Phase 2 continues until about 6 to 12 weeks post-op. The objective in this phase is to engage the athlete's full active range of motion, return the athlete to full rotator cuff strength, and restore more strength and balance.
In addition, athletes may bike or walk to maintain cardiovascular fitness.
One common exercise during this phase is the plank. Variations may be used depending on the athlete's ability. Another exercise is the banded internal and external shoulder rotation in a neutral position. A cloth or towel should be used to keep the elbow in line with the shoulder and prevent unwanted strain on the joints.
Next, Phase 3 begins when the athlete has completed the goal of Phase 2 and usually ends 10 plus weeks post-op. At this point, the athlete will be out of a sling and will have good day-to-day function of the joint. Cardio may be expanded to running as long as it does not cause pain, but swimming should be avoided. This phase focuses on full active range of motion in all planes of normal shoulder and arm movement and increased shoulder strength. Once the plank is mastered, the athlete can move to planks on unstable surfaces such as a foam pad or Bosu ball. On top of this, athletes may progress to banded internal and external shoulder rotation at 90 degrees.
Then, Phase 4 progresses from Phase 3's end until 16 plus weeks post-op. This phase is concerned with heightened range of motion and faster, more intense movements in numerous planes of motion. Also, the rotator cuff strength should continue to be improved at 90 degrees and tested frequently. An exercise to further improve range of motion is a sleeper stretch. The athlete should press gently and slowly on the arm. Shoulder strength exercises can progress from planks on unstable surfaces to push-ups. Once comfortable with regular push-ups, a Bosu ball can be added to increase difficulty. Rotation at 90 degrees of shoulder abduction is necessary during the stage. Band difficulty may be increased or bands can be swapped for weights.
Finally, Phase 5 ends at about 22 weeks post-surgery. The goals of Phase 5 are similar to the goals of Phase 4. In Phase 5, the intensity of rehab increases to prepare the athlete to return to play. The intensity of cardiorespiratory fitness should continue to increase to align with the athlete's demands. At this point, the athlete should bike, walk, run, or swim. Another step towards returning to play is the implementation of a sport-specific overhead throwing program. This program may begin with general overhead throwing motions against a trampoline with a tennis or lacrosse ball. It can then progress to a weighted ball and eventually a sport-specific implement.
Overall, slap tear rehabilitation can be a lengthy process. Thus, friends, family, and coaches and trainers should be aware of the athlete's emotional state at all times. Individuals should look for behavior out of the normal for the athlete. These behaviors may include, but are not limited to, decreased appetite, sleep problems, depression, pessimism, low motivation, the feeling of isolation, and identity crisis.
To combat this, adherence and outlook are vastly important to the athlete's emotional state.
We hope you enjoyed our presentation and are better equipped to handle and treat slap tears. Thank you for watching.